the update in terms of the next webinar will be on March 21st, just as an advertisement. It'll be focusing on suicide prevention, so set that aside in your calendar, and we'll be looking forward to hearing from you then. Just to also let you know, we will be recording this webinar, so it'll be available later as an archived webinar, so it's important to know. In terms of the question and answer period that will occur after about 1 hour, 1 hour and 10-minute presentation you'll be hearing from, please type in questions into the window that you see here on your computer screen. So it'll be much more efficient to read questions in a moderated question and answer session that will occur at the end of the presentation. It'll be a moderated question and answer session. So really delighted to have so many people participating today, and what I want to do is just first introduce the speakers, which are both good friends and colleagues who will be presenting today. First, Dr. Kristen Berry is a leading research scientist with over 20 years of experience in substance use disorder intervention, development, research, and training. She's a technical expert and provides technical assistance on the current SAMHSA CSAT Older Americans Behavioral Health Technical Assistance Center. She's a research professor in the Department of Psychiatry at the University of Michigan. She's a national and international leader in demonstrating and developing substance abuse and use disorder interventions with a particular emphasis on brief psychosocial interventions that address substance misuse in a variety of healthcare settings. We're glad to have Dr. Berry presenting along with her colleague, Dr. Fred Blow, who is the scientific co-director on this Technical Assistance Center and is an internationally known expert on behavioral health in older adults with more than 30 years of experience coordinating, conducting, and directing research studies in centers. And I'm sure you know his reputation precedes this webinar, and he's documented and studied the efficacy of the SBIRT model as an evidence-based practice for older adults, and has done pioneering work in prescription and illicit drug use among older adults. He has many other roles at the University of Michigan, doing as a professor, doing research in many different areas, but he's, I think, widely known as an internationally known expert in older adults and substance use disorders. And pleasure to introduce both of them as colleagues and friends for this first webinar. So, Chris and Fred, it's all yours.
Thanks so much. Good everyone. We're really delighted to be here today to talk about what we think is really an up-and-coming area that's going to be of great importance as we go forward with the aging of the baby boom generation. And we hope that you'll gain today some new understanding of what is the relevance of alcohol and prescription drug misuse in older adults, and some of the techniques that have been shown to be effective in addressing these issues. You already have your phones on mute. We would appreciate it if you would do so now, because it would be less disruptive to the presentation. So you're going to forward the slides, and if you go to the next slide, that'd be great. So this is just our formal information, which you just skipped over. And what we're going to do today is talk about a broad overview of the problem and give you some key things that we think are important for you to know about. We'll talk about screening identification methods and what are the ways that we know work in terms of identifying people who may be having problems with alcohol and other drugs. And Chris is going to take over after I cover those two topics and is going to give more details about brief motivational interventions, evidence-based practices that have been demonstrated to be very useful for a large group of individuals, including older adults. And then end up with future needs and questions and answers. Now, so we want to just show you what we know a little bit about nationally percentage people who use alcohol and other drugs in the later life population, older adults. And these are data from SAMHSA. And they're a nationally representative sample, and the numbers actually are increasing now, we know, over the last several years, but these are from 2005. And what you can see in this graphic is that, and it's by race and ethnicity, because I think that's an important element to this. What we see is that by far the largest number of people in the population are using alcohol in later life, people over the age of 65. 40% of non-Hispanic whites report that they consume alcohol at least a little bit during the course of a month. 30% of non-Hispanic blacks or African Americans are using, and about 33% of Hispanics or Latino are using alcohol. The numbers are shifting pretty rapidly, as we know that the aging baby boomer population is getting to be now this year 66 years old, and are starting to reach the later life period. We know that their use of alcohol in particular is higher than in the current cohort of older individuals, so we expect that the overall use rates will increase. If you look at the problematic use of alcohol, that is binge alcohol use, drinking 4 drinks on any drinking day, as defined by binge drinking for older people, the rates are getting to be higher, and higher in minority communities. They're 14% among non-whites, but still in the white population of older individuals, about 12% report binge alcohol use, which is a dangerous form of alcohol consumption, placing people at higher risk for a lot of negative health consequences like falls and emergency department use, and certainly medication alcohol interactions. The number of people who are really the heaviest users, the most problematic use in the population, the current older adult population, is relatively small. You'll see it's 3-4% there. But that is rapidly changing, as I say, and I think it's going to be much greater in the future. And if you look at the illicit drug use, that is the use of illegal substances, marijuana, cocaine, and other substances. The rates are very low, though we've seen a real spike in the use of marijuana in the older population, probably, again, being driven by the baby boomers, who have a lot more exposure to illegal drugs and have a lot more acceptance of its use, especially marijuana. Left off the first element of the slide, which is cigarette use, and I think it's really important to point out that despite all of the warnings that we've had, despite all of the prevention messages around the dangers of nicotine consumption, especially cigarette use, still a large portion of the population continue to use in later life, and it's a great opportunity for intervention strategies for nicotine dependence also. And much of what we are going to show today about brief interventions were pioneered with smoking cessation programs and can be used very effectively to also influence nicotine use. So kind of a snapshot picture of what we know about older adults currently by race and ethnicity. Again, this dynamic system that's changing very rapidly with the aging baby boomer generation. Next slide. Something I like to always point out is that we're really not only talking about alcohol use as the main drug that people use, but we are also really interested in the combined problems of alcohol and medication misuse. And it's 19%, almost 20% of Americans have been estimated to be affected by the combined use of alcohol and medications. About 150 commonly prescribed medications have significant alcohol interactions with other individuals and have warnings against the use of alcohol with those medications. And the drugs that are most problematic are the psychoactive drugs. It's what we focus on a lot in terms of our intervention strategies. So we're really interested in the sleep aids, we're really interested in the anti-anxiety agents, and we're really interested in the pain medications, so the opioid analgesics. These will have significant alcohol interactions, so small amounts of alcohol can actually interact in a negative way, making the situation worse in terms of potential risk for overdose, for significant negative comorbidities related to their combined use. Next slide. We also know that alcohol use can impact functional functioning in older individuals. And important work that's been done by Allison Moore, who's at UCLA, a colleague of ours, looking at instrumental activities of daily living, and when do older men and women get into trouble with just basic daily functioning, daily activities. She found that more than 7 drinks per week was associated with impairments in ADLs. And there were also impairments in advanced activities of daily living, something that we're really concerned about if we want to keep seniors in their homes. So relatively low amounts of alcohol can have an impact on activities. And then if you get to more than 3 drinks on any drinking day, this is getting into the binge pattern of consumption. We know that these 3 drinks or more per occasion are associated with lots of impairments also. So something to really keep in mind as we're trying to talk with individuals about the role of alcohol in their lives and the potential dangers of moderate consumption of alcohol as people get older. Next slide. We also know that there's a lot of interactions of pain and alcohol misuse. And, pain is a common issue that older individuals face. And we also know that older problem drinkers report a lot more severe pain, a lot of disruption of daily activities due to their pain, and much more frequent use of alcohol to manage their pain compared to older non-problem drinkers. So when we're starting to look at the issue of pain in older individuals, we want to make sure that we also pay attention to their drinking, because that interaction can really place people at high risk. If they're taking pain medications, they could have a lot more risk for overdose and other problems intentionally by also drinking alcohol. That more pain is associated with more use of alcohol to manage the pain. So as people's pain severity increases, we know there's a lot more pain, a lot more alcohol use to manage the pain, as well as other medications. And the relationship is strongest among those that might be defined as having drinking problems compared to those without. So another part of the puzzle. Next slide. Another perspective, and that is that problem alcohol use can increase caregiver burden. We think about the whole person, and we think about, well, what do older patients in terms of their families and burden on families and burden on caregivers. And as older individuals increase their alcohol use, we also know it increases the burden of caregiver. This is an important study that was conducted focusing on geriatric patients undergoing assessment for cognitive problems. I think 18% had a current or past alcohol problem, and you see about a third of the men and about less than 10% of the women. But some of those with current or past problems were actively drinking alcohol. Patients with a history of problem alcohol use, regardless of whether they were current users and regardless of their cognitive status, exhibited a lot more behavioral disturbances, agitation, irritability, disinhibition. These are the things that caregivers really are burdened with and have a lot of problems with. And so the issue of alcohol use is an important one in terms of what happens with the loved ones that they're trying to care for. Kids of patients with current and past alcoholic problems also reported a lot more distress, a lot more caregivers distress. So a combination of things, and so even moderate alcohol use can impact caregiver burden. Next slide. Alcohol can have a lot of different impacts, and what we really want to try to get to is to figure out, well, how do we screen for people with that might be having some higher use of alcohol than we would recommend, or maybe even people that are starting to have problems with alcohol. Well, there's all kinds of barriers to identification, and I like to highlight these because I think they're really important as we start working on a way to identify people. And identification is the first step in really conducting targeted brief interventions. First is that we have lots of ageist assumptions about what we think an older person who may be drinking too much or drinking over recommended limits looks like. And we have to be very careful about ageist assumptions, that if focus only on those with the most severe problems, the people that are easy to identify because they have a lot of problems related to their alcohol, we're kind of missing the boat. We need to bring our perspective and recognize that those that are maybe lower consumers, but actually people that have a lot of chronic illnesses or are taking a lot of medications, may be very high risk for problems, and we're careful not to assume that people just won't have problems because they don't look like they're a drinker or look like they're an alcoholic. We need to be careful about those ageist assumptions. They also recognize symptoms. The symptoms are subtle, they're complicated, they are a multitude of symptoms that mimic other problems. So it's easy to say, oh, Mrs. Okay is really having problems related to her memory, when in fact a lot of that may be related to her use of alcohol. Or maybe, Mr. Smith is really depressed, and therefore, of course he's not going to have these kinds of, he's not going to take care of himself, he's going to look disheveled, etc. In fact, those symptoms may be symptoms of his use of alcohol. Of knowledge about screening and how to use screen and what are the most efficient screening mechanisms. We'll get to that in a minute. We want to emphasize that we actually know a lot about how to screen for alcohol use and misuse, and we should apply what we know to broad populations of older people. Attempts of self-diagnosis, the description of symptoms attributed, the attempts of self-diagnosis, that is, identifying oneself as having a problem with alcohol or being an at-risk drinker, is worse in older individuals. There's lack of awareness and lack of self-awareness that they may be having a problem. And again, a lot of the symptoms may be attributed to aging processes or disease, with that it may be focused on their use of alcohol. And then finally, many people don't self-refer or seek treatment. If you think about younger individuals get into treatment, they get into treatment mainly because of problems with workplace or spouse or families, or their criminal justice involvement, drinking, driving arrests. Individuals have challenges in all those areas. They may not work, they have a lot of family supports, they may not drive, and therefore don't get into problems with criminal justice. So they're less likely to self-refer and to seek treatment. Even though most older people see physicians regularly, many of those are at risk, identify or seek services, and don't get referred for treatment. Next slide. We wanted to cover briefly what we know about, what we recommend about screening in terms of instrumentation, and we have these instruments on our website as part of the technical assistance that you'll be able to access easily. The idea is that what you want to do is you want to capture alcohol consumption. You want to know about quantity, frequency, and binge drinking heavily on any drinking day. One of the efficient ways to do that is to use the first three questions of the audit, the Alcohol Use Disorders Identification Test. It's called Audit C. It's an efficient way to get at frequency and quantity and binge drinking. We recommend basically 4 questions to 3 audit questions, and then the first question is, do you drink alcohol at all? So that you can identify people that you don't need to screen further. Alcohol consumption is an important element. Another element is related to alcohol consequences. You also really want to know whether a person is having any problems related to their consumption, and so therefore you want to get at consequences. A number of validated instruments, including one we developed, the MASG, the Michigan Alcohol Screening Test, geriatric version. There's a short version as well as a long version. And it really focuses on our consequences. So hand in hand, you would recommend that you absolutely ask about alcohol consumption, quantity, frequency, and binge drinking. And then if you want more information, you can efficiently ask about alcohol consequences and understand whether someone's having problems. Another strategy that Chris Berry really pioneered a while back is using something that she developed called the health screening survey. It embeds the drinking questions with other health behaviors and ways to diffuse the potential reactivity that some people might experience if you're just isolating the alcohol consumption questions or the consequence questions. It can be embedded in a variety of health behaviors. That instrument is available. She embedded them with nutrition, exercise, smoking, and depression questions, but they could be others. So as you're thinking about efficient screening within your settings, you might want to use some of these instruments around consumption and consequences as an adjunct or as an additional piece of information of other screening that you're already doing. Next slide. So I chaired the panel on substance abuse in older adults that SAMHSA put together, focused on treatment improvement, and we put together a national panel of experts to recommend a variety of things. And one of the things we recommended as part of that treatment improvement protocol was that every person over 60 should be screened for alcohol and prescription drug misuse as part of their regular physical examination. And we recommended using the so-called brown bag approach, where all medications are brought in for a review for their current use, whether there's any disused medications, for their medication interactions, as well as for their alcohol medication interactions. It's an efficient way to assess whether someone's at risk for negative consequences. You want to rescreen if some physical symptoms are present or if the older person is undergoing major life transitions. We recommend strongly universal screening, that is, regular screening of an entire group of individuals as part of routine practice. I guarantee you, if you focus only on those that you think are having problems, you've really missed the bulk of individuals who might benefit from these interventions. So we really recommend more broad-based screening, especially as the baby boomers age, because there's lots of evidence that they continue to drink into later adulthood at a much higher rate than younger individuals. So next slide. What you want to do is ask direct questions about your concerns. One of the big questions that often comes up in our trainings, Chris and I have experienced this many times, is that, we can ask personal questions like alcohol use. Well, you can, and it works real well, and there's not often much pushback. If you preface the questions, linking the questions to your concern about their medical conditions or their other health concerns, and careful not to use stigmatizing terms. One of the big things that the current cohort of older people are really worried about is that you're going to figure out that they are a heavy drinker, that you label them an alcoholic, which is regarded by the current cohort of individuals a moral weakness. It's one of the worst things you could be. But we want to make sure that we are diffusing that and not in any way indicating or suggesting that someone is labeled with a stigmatizing term. So if you say we're interested in at-risk drinking, we want to look at health and health behavior, and we're really concerned about how your use of alcohol may interact with your medications and your health, then it becomes a different kind of dialogue and a different discussion entirely. Next slide. Transition a little bit into motivational brief interventions and intervention methods. And I'm going to give you a little bit of overview and background, and then Chris is going to take over and talk about some of the specifics related to the evidence of effective brief interventions, the evidence-based practices. So I show this slide because I think it really contextualizes the spectrum of interventions that we all have and we do have in our toolkit. As you can see on the left-hand dimension, we're talking about prevention, education, brief advice, brief interventions, pre-treatment interventions, and formal advice treatments. And at the top, you can see a whole range of drinkers, ranging from the no drinkers, the abstainers, all to the chronic, severe, dependent individuals. And what to really emphasize with this is that prevention and education works and is very effective in particularly avoiding people getting into serious trouble with alcohol. And much of what we think of when we think about screening is an opportunity to provide people with educational materials about what are some of the benefits of alcohol use, but also what are the problems, what are some of the negatives or the risks. So prevention education is an important element. BRITE advice is a very limited thing and is focused on a often 2-minute or 3-minute conversation done by a healthcare provider with an older individual, focus on a little bit of advice about the dangers of their alcohol consumption and the potential for the alcohol use as might interact with their psychoactive medications or the dangers of their psychoactive medications. And it's very, very targeted, very brief, and a little bit of advice in the context of a health visit. People say, that's not very effective, why even bother? Well, if you think about it, a 2-minute interaction or a 3-minute interaction actually will get anywhere from 10 to 15% of the people to change their behavior. That people do respond to brief advice. It's not the best way to do it, but it's not worthless either. So we want to make sure that that's not left out, because sometimes having a healthcare provider reinforce the idea that you're going to dialogue with the individual about their medication use and their alcohol use can be very, very productive. Briefings we're going to spend a fair amount of time on after this. They're usually anywhere from 15 to 20-minute interventions. They are typically 1 to 5 brief sessions. Mostly we focus on 1-session brief interventions, sometimes with a booster, sometimes not. And they are targeting a specific behavior. In this case, we're talking about people's use of alcohol and psychoactive medications, but they've been used, as I've suggested, with smoking, with improving nutrition, with increasing mammogram rates, with all kinds of health behaviors. So these are used in a lot of different ways, and we'll talk more about that in a minute. So I don't know what that was, but I'll continue. The pre-treatment intervention is a often motivational-based intervention that is aimed to get the individual to think about going to treatment. Many are resistant to thinking about formal specialized treatments, and sometimes motivational techniques to motivate people over periods of time and actually encourage them to go to treatment. Finally, we don't want to forget the utility and the importance of formal specialized treatments. We know it works for this population for older individuals. In fact, it may work even better than with younger individuals. And we want to continue to expand our abilities to meet special needs of older individuals in community settings with specialized substance abuse treatments, by educating providers about how to do that, substance abuse providers about how to address the specific needs for older individuals, because it can be very, very powerful for individuals to get into specialized treatment. So that's the spectrum of interventions and the kinds of things you might want to be thinking about as an array of services that are needed in community settings, so that you address all of the people that might identify through screening. Next slide. We like to show this slide as just a conceptualization of how we typically have thought about alcohol and alcohol problems. On one dimension, you can see is alcohol use, ranging from no use to heavy use. On the other dimension is the bottom dimension is alcohol problems, ranging from no problems to severe problems. We have organized all of our thinking and our care, our health care, around the people that are the heaviest users and the have the most severe problems, those that have alcohol or substance abuse or dependence. This is the tip of the triangle, the small portion of the overall population. As I suggested earlier, for older adults, it's probably no more than 3 or 4%, and probably less than that for women. And it is a small portion. It's an important group because they have a lot of negative health consequences. But if you only focus on that group, you really miss the major problem that people have in later life, and those that we classify as at-risk or problem drinkers or problem users of medications. And we'll try to identify people earlier to find out that they have risk factors that place their health at risk, that they over recommended limits, or they're using their medications, their psycho medications in an unsafe way, so that we can prevent people from developing full-blown serious problems or other health problems related to their use of alcohol or medications. And so we really want to try to broaden the perspective here and to give you more rationale for thinking more broadly than just the dependent individuals. Next slide. It's to talk about definitions, because I think that I've been throwing around a lot of terms so far in the presentation. I think it's useful to look at the World Health Organization drink definitions. I think the most commonly common area that people focus on is the so-called harmful drinking. This is alcohol or medication use that causes complications, and these are what we typically think of as people with abuse or dependence. More importantly, we also want to think about hazardous, or what Chris and I and others have talked about as at-risk or medication use. And that use of substances that increases the risk for complications. That is, it increases the likelihood that people will have negative consequences. And the third group, which is we call non-hazardous drinking, it's alcohol without any clear risk of complications. This includes the beneficial use, which we know that certain beverage alcohol, particularly wine in particular, has some health benefits for selected individuals. And so we want to ensure that we can also educate people about what is non-hazardous drinking. Some people in the past referred to this as social drinking. I don't like that term. It has value connotations. So we stick to non-hazardous drinking as a way to describe it. So a lot of the action here is in this hazardous drinking or the at-risk drinking group, and try to focus on that as a key target for brief interventions. Next slide. So interventions have been around for many years. The early trials for smoking were done in the early 70s, landmark studies in Great Britain. And then subsequent work that was done in the U.S. Chris Berry did the U.S. trial on brief interventions in primary care. As part of that trial, did a specific of it for older adults. That's Project Gold, studying older adult lifestyles. Basically, in Wisconsin, primary care screened individuals when they came in for a health visit, and 5 people that were at-risk drinkers, and then did a physician-based intervention that resulted in reduced consumption at 12 months. About a third to 40% of people changed on the basis of this 15-minute intervention that was physician-focused. We did a larger trial with Chris's help, which again focused on an elder-specific motivational enhancement session, identified people in primary care with screen measures, and then conducted in-home visits and had social workers and psychologists delivering the intervention, and compared to usual care, no intervention group, it reduced the at-risk drinking at 12 months, at similar rates to the original trial that Chris did. Then there have been several other major projects, randomized trials older adults, and similar results have been shown with bells and whistles. The idea is that a 15 to 20-minute guided motivational brief intervention reduces risk drinking in older individuals a much higher rate than those that receive control conditions. The slide shows some of the current knowledge that we have around this, including that brief interventions can reduce alcohol for at least 12 months. Pretty cost-effective. If you think about it, if you can do a 15, 20-minute intervention and it's effective over a 12-month period, it can be really very, very powerful. Motivational enhancement is effective for older adults. We weren't so sure about that when we started all this, but in fact, you can motivate people and they can be motivated to change their behavior. It's accessible and can be conducted in a whole range of settings. We've done it in emergency departments, in hospitals, as in home and in congregate meal sites and in social service settings, a whole range of settings. And it is to reduce alcohol-related harm and alcohol-related healthcare utilization, including emergency department use. And so I think it's a really important practice. The U.S. Preventive Services Task Force has given these series of interventions a rating of B, which is not bad in terms of preventing illness, and I think it's a pretty effective way to think about what you might do in terms of an evidence-based practice in community settings. Slide. So how that the interventions are effective, the big question is, so for whom and how can they be implemented? And I wanted to just give you a little brief project that Steve Bartels and I had a small role in, called the PRISM study, which is a primary care research in substance abuse and mental health for the elderly, supported by SAMHSA and the Department of Veterans Affairs. And next slide. That was done to compare two service models for depression and at-risk alcohol use in old adults, and it was ideas of comparing integrated and collaborative care, which included identifying people in primary care and then delivering an intervention within the primary care setting in that actual setting, including at-risk alcohol use, versus referring people to specialty clinics to that kind of care. I'm going to focus on at-risk alcohol use today because that's the most important piece. There are 10 sites or 14 sites nationwide. I don't remember at this point. Anyway, I did all the training with another collaborator for this to delay at-risk alcohol use intervention in primary care or in specialty care. And so the next slide shows you a little bit about some of the results, which is that there was a lot of great engagement in care for those that got integrated care, that is co-located within primary care, compared to those that had to go to specialty care. In some cases, the specialty care was in the same building, but it still was in a different group. Within the integrated care, those receiving care in primary care, 43% received at least one brief alcohol intervention. Only 9% received, in this case, we recommended 3 brief sessions. Only 9% received 3 brief sessions, the recommended amount. And for those that had a comorbid depression or anxiety problem, fewer people received the intervention. Interventions were done, they weren't done all that well, and this was in the best possible circumstances. That we provided the sites with lots of training, with support, with resources to make it happen, and it was very challenging to make it happen. Significant reductions in both the frequency and quantity of drinking and binge drinking over 6 months. And those that went to specialty care compared to those that had integrated care, there are no differences in the drinking outcomes between the models. They did equally well depending on whether they got integrated care or specialty care. The dot is that there was minimal uptake and implementation of the brief alcohol intervention in both groups. Huge barriers to making this work. And so I wanted to emphasize that as you start thinking about implementing alcohol brief interventions and integrating medication interventions within your settings, don't underestimate the challenges of actually doing the implementation. Next slide. The work that's been done by SAMHSA and a lot of individual researchers. We have active projects underway here in Michigan also using the so-called SBIRT model. This is screening, brief intervention, and referral to treatment model. It's an initiative, next slide, that focuses on implementing screen intervention and referral to treatment in largely medical settings, although it's been broadly construed to other settings. The focus on non-dependent substance use, as I suggested, the at-risk use. It emphasizes simple screening followed by one session of brief intervention, education and motivational interviewing. The referral to treatment piece is for specialty care, the deep end services, and other care as needed, and is an active referral to those settings. There were competitive 5-year grants awarded to states, to governors, and there were cohorts across 2003, 6, and 8. And I think now a little more than half the states have received these funds. Next slide. One state, Florida, received funding to focus on older adults, to do this SBIRT program within the older adult population. And this project was called the Florida BRITE Project. It was state funded. There was some pilot work that was done originally. It really provided large-scale brief screening and then one brief advice, brief intervention session. But they had flexibility of adding more brief interventions and brief treatments if they wanted to and if the person needed it. Next slide. So, BRITE was offered in a wide range of settings, and we could learn a lot from them, have learned a lot from them about the kinds of settings that this can be done in. It expanded from 4 sites to 21. They were in 15 counties. Like everyone else has had a challenge with how do you deal with prescription drug misuse. Part of the challenge that they had was how they defined it. I think we've gotten further along in our understanding of it, and our advocacy, Chris and mine, about focusing on just the psychoactives, not the whole world of prescription meds, is probably a good way to go. But they still had a lot of challenges, and they were really trying to include all medications, which was very, very difficult. Next slide. They screened lots of people. They had a lot of challenges in getting the site up and running, and it's been really successful in a lot of different kinds of settings with different challenges in each of these settings. Next slide. The Florida BRITE Project is that they're able to demonstrate with large-scale implementation that it can work, but there needs to be a lot of emphasis placed on making sure that people are following through with identifying people in a systematic way using screening, conducting brief intervention in, again, systematic way, and making sure that people are trained to be able to deliver the intervention. Not to forget that some people will be identified that are more serious problems that really need to be referred to treatment. So we'll now turn over the session to Chris Berry, who's going to spend some time now talking about the actual brief intervention, the evidence-based practice.
I'd like to be able to talk some about the brief intervention session. I do want to say that although there are challenges in setting up brief intervention systems in any kind of setting that deals with younger or older adults, the some very sort of simple, reasonable ways that we've really come up with over a number of years that I think will be helpful in terms of doing that to make it a little bit easier. And we found that being systematic is probably the thing that works best. Anything that we can do that embeds the screening, embeds the interventions in our usual practices in a way that they're just going to get done, make it much easier. And for many of your sites that you work with, you've been doing other evidence-based practices, and you've experienced a lot of the same issues be that. So if you could then go to, in this next slide here that you're looking at, the aspects of an effective brief intervention, basically based on the FRAMES model. The FRAMES model was developed quite a long time ago. It includes feedback, responsibility. The person has responsibility for their life and for what they're going to be doing. There's some advice involved in it. There's a menu of options that people choose from. They help negotiate what's going to happen and what they're going to do. And it includes empathy and some social support for self-efficacy. And that means sort of empowering people to feel they can do things, make some tweaks in their lives that will help them as they go along. Most of the brief interventions have been done in a lot of different kinds of settings, and most of the brief interventions use a workbook. And the development of a workbook is an important issue because it gives something for you to follow as a clinician and for the client to follow along with you. Generally, when we use a workbook, we sit next to people and we do it with them. That works out the best. We've found that way, from a logical standpoint, people don't always have to be looking at you. You don't always have to be looking at them. You can both be looking at the workbook, and it becomes more of an educational, preventive kind of experience.
Sorry, this is Fred again. We have Power Blip here. They've been working on our backup power systems. So luckily we have our systems. We have another computer set and running at the same time. So we'll just say advanced. Can you hear us okay?
Perfectly. Thanks for the update.
We lost one of our screens, which was where the live meeting was, but we have another one that is my laptop that we've got running. So luckily we thought about doing that. So
okay.
we just want to make sure it's okay on your end.
Yeah, we're good. Thank you.
Okay, great. Thank you. So the next slide is on confrontation versus motivational interviewing. And in interventions, we really take a motivational approach. And it is an important approach. It's slightly different in tone and content from traditional substance abuse treatment. But I would say, having worked with substance abuse treatment centers now, both Fred and I have over a number of years, that they're changing their approach also. And so we're seeing more places are taking kind of a motivational approach to working with people. What the motivational approach basically does is it emphasizes labels. It emphasizes personal choice and responsibility. It's concern, it shows some evidence for what's been going on. And one that we do is we roll with resistance. And I'm going to take you through the steps of a brief intervention, and then talk a little bit about what we do and how we do that. And resistance with reflection. We don't argue with people as part of this, and we don't insist that they accept a particular way of thinking about their issues or what we want to be dealing with. And the goals and the strategies are negotiated. And that's probably one of the keys to this all, is people do have some choices, obviously, in what they're going to do. And if you're negotiating with them in sort of an upfront way, I think you might be surprised to know how well that works. Knowing that we have choices helps us all to make better choices. Next slide. Okay, the things for brief interventions we've talked about already. They've been done in lots and lots of kinds of settings. The next slide, please, is the steps of a brief alcohol intervention. I'm going to go through these each individually. But the first thing we do is we identify future goals. We summarize health habits, which is why we have questionnaires that we give people in screening. What about standard drinks? We talk about the types of drinkers and/or people who are using psychoactive medications. We make sure that in our brief interventions we include psychoactive medications. So we are asking some questions about that so we can, one of the most dangerous combinations that people can be taking at any age, certainly, but certainly in later life, is a combination of psychoactive medications like the opioid analgesics, benzodiazepines, the prescription medications for pain, sleep, and anxiety, and to drink in addition to that. I think probably one of the things we all just saw this last week was Whitney Houston's death, which was an untimely death, and we don't know exactly what the cause was, but there's certainly been speculation that it could have been a combination of alcohol and prescription medications. And we see this all too often. And as people age, I think you all know that our bodies change. And when our bodies change, we don't metabolize alcohol or medications as easily or as well. We don't clear them as well. So the problems that we see earlier in life could really be enhanced later on. So then this is also looking at reasons to cut down, looking at an agreement, either be abstinence, not using any alcohol, or it could be what we might call controlled drinking or non-risk drinking. And look at risky situations and some alternatives as part of it. Next slide. So the first thing we do in the workbook is we identify future goals. Now, why would we do that? Take the time to do it. Well, the reason we take the time to do that is that we really want to know what's important to a particular person. When you look at yourself, when you look at your clients, you know that different things motivate each of us. And so what we're really trying to do is come up with what's important for people and develop some discrepancy in what they're doing, use of psychoactive meds and or alcohol, and how that might impinge on their ability to reach their goals. For older adults, one of the keys is that they want to stay as independent as they can. That's an important thing to be thinking about. The next slide, we have a summary of the health habits. As part of the workbook, there's a place to put in how people answered the questionnaires that we give them, have a little information going in. And so we're able to give them some feedback. Sometimes on their physical and mental health functioning, sometimes on some of their health habits, nutrition issues, tobacco use. Usually what we do is we go through the various things we've asked and say it looks like you've been smoking cigarettes. It looks as if you've not been exercising much, that you haven't gained or lost weight. Things have stayed steady with that. And it looks as if you've been drinking at this level, and it looks as if you've been taking some medication for pain. That we would say is, are there any other health habits or behaviors that you'd like some help with? We do that because everybody will pick something other than alcohol or the psychoactive prescription meds. So give them a chance to pick that and to tell them, well, you know, we can help. We have programs that we can refer you to for that. But today what I want to focus on is alcohol or psychoactive meds or both. So we talk about, in the next slide, we talk about standard drinks, type of older drinkers. It was a pie chart for that and kind of show people where they fit. Because I think it's important for people to have a sense of what level of alcohol consumption they have and how it compares to other people in their age group. Most people are using more alcohol than that is probably healthy for them. Often either have friends, relatives, children, other people who are also using more alcohol. And they have been using this amount of alcohol all their life. And from the time they were an early adult, they drank 2 to 3 drinks a day, every day. Well, they're 70, and 2 to 3 drinks a day has a much bigger impact on them than it might have had when they were 40. So I think that's an important thing to keep in mind. So this helps people. Now, the next slide, we'll look at what standard drinks are. And we talk to people about standard drinks. And the important thing about standard drinks is all these drink types that are listed here have equal amounts of alcohol in them. In the U.S., it's basically about 12 grams of alcohol, which means that a 12-ounce beer, and that's not a big beer, this is 12-ounce beer, is equal to 1.5 ounces of liquor, which is whiskey and vodka, etc. I don't know if it was even a full shot glass. It's equal to 5 ounces of wine. And if you notice on that wine glass, that's not a full glass of wine. So if you're out someplace and they pour you a glass of wine that goes all the way up to the top of the wine glass, that might be 2 drinks. It's equal to a small glass of sherry, and we find that this is still for the older adults now, this is one of the drinks of choice for older women. And it changed with the baby boom cohort. Right now, that's what we're seeing. And it is equal to a small glass, about 4 ounces of a liqueur. Which we see a lot less people using that, but where we really see what people use are the beer, the wine, and I'm sure for some women at this point, and are all looking at drinks per day. And what I think I should talk a little bit about the standard drinks and what a drink per day would be. For older adults, the recommendation for how many drinks per day, if you're not using psychoactive medications, is 1 drink a day, 1 standard drink a day for men, and a little bit less than that for women. It's listed as 1 standard drink, but the recommendation is usually a little bit less than that. Binge drinking for women over 60 is considered 3 drinks or more on a drinking occasion. For it is 4 drinks or more on a drinking occasion. So this is less than for younger adults. And the reason for that, as I was talking about, was how our bodies change as we get older. So on the next slide, we go through reasons to cut down or quit. And we have people identify some positive and negative aspects of their alcohol use, to their medication use, because we really want to figure out what are the barriers to making changes, and we can work with them on some benefits of changing. If people and kind of It's called Keeping the Decisional Balance. It's give away the options a little bit. Now they will decide to change their drinking or their psychoactive medication use right away. But they have a workbook that they take home with them. They don't keep it, they have it. And it gives them something that they can think about. And we often find that people have to think about things for a little while, and then they make changes. The nice thing with the older adults is this is a group who really wants to function well and wants to function as well as they can. And we have found this across a lot of different populations. So next slide, the next part of the brief intervention is the drinking agreement or psychoactive medication agreement and the plan. And we then we do a short negotiation about what would be a reasonable amount to be. If this is a person who's not using psychoactive medication, I might start by saying, well, you know, I think it would be reasonable to have maybe no more than one drink a day, no more than 3 days a week. What do you think? And the reason we give people an opportunity to say what they think is it's if they say, oh, come on, I'm not going to do that. I want to do that. And we'll say, okay, well, what do you think would work for you that would be within the guidelines? We could try drinking 1 drink a day. Okay. Remember we talked about the standard drinks. What usually drink your glass of wine in? And that's kind of what kind of glass they drink it in, because if it's a tumbler, that's not a glass of wine. So from a drink standpoint. So we want to make sure that we've covered that and give them some options. And some people will ask me, well, do you really think I should do this? Do you think it will help? We talk about some of the issues they've been facing, and in general, most people are facing some physical health changes. They may be facing some social changes. They may be lonesome. They may not be getting out. They may have lost a partner. And we try and think of some other things that they can do and ways for them to find some fulfillment. And by giving people choices, it does increase their sense of responsibility. So, first session, or we have people come back at another point, and sometimes I'll have people come back depending on the situation. Usually, we do the interventions as a standalone, one time, anywhere from 15 minutes to half an hour intervention. But also, I'm obviously willing to have people come back if they want to. And so what we do is we give them drinking diary cards, which we'll talk about in a minute, and we suggest that they fill those out, and medication diary cards they can fill out. And if they have a bad day, just be as honest and accurate as they can be, because that's how we're going to figure out what to do. So if we decide that it would be good if they came back, when they come back, we might discuss risky situations then. What are the situations that triggered something to happen? It might be that on Sundays, they visit with their wives and the kids fight, the wives don't like each other, my sons like to watch the game, but then they drink beer, and I wind up drinking more beer than I was thinking I was going to, because they all make me nervous. These are not unusual scenarios, and we've heard many, many kinds of scenarios. So what people think about, what are some ways to handle that a little bit differently? How might you want to do this differently? And so that's some of what we do. We train people, Fran and I train people to do brief interventions. We've trained people all over the country to do this. We certainly are more than willing to help any of you with anything you need in setting up how you would do brief interventions, how you would do screening, and we're available for that as part of this technical assistance, so please do not hesitate to ask us. The slide is on fidelity, and it's important that we follow to do this, because this has been tested actually fairly extensively. The older adult intervention has been tested in about 5 or 6 big trials now. The young adult intervention, which is a very similar brief intervention, has been tested in over 100 trials. And most of the, I think 95% of the trials have come out with positive results. So interventions work. As Fred mentioned earlier, getting them in place has really been the difficult part. So we try to follow some of the core elements. We pre-screen so that we ask a few questions and taken care of all people that we don't have to ask any more questions to. We do a little more of a screen. We do brief intervention. We fill out an intervener exit form so that we know what parts we did and what the person decided to do. We give the person the workbook. We refer people to treatment or other services if they need it. We'll do follow-up if needed. And so that's kind of how we do this. We're embedding screening brief intervention. The next slide is very important. It helps organizations offer screening and brief interventions on a routine basis. We can try to embed pre-screens in an initial intake, registration. It can be done in health fairs, in emergency departments, primary care. We've seen if people have a positive pre-screen, these can be pretty easily done. People can fill out the questionnaires themselves often. You know, people originally, when we've have said to us, well, older adults aren't going to be able to fill this out. Well, we've screened probably about 20,000 older adults now over a number of studies, so, well, they can. And that's really the good news. There's some people who can't and who can't see quite well enough. You can get some help in filling it out from somebody at the staff. So the prevention, if you have a positive full screen, then having a short brief intervention with a workbook that makes it very easy to do it. Typical summary for all of this is, the next slide, is we want to assess for consumption and consequences. We consider people's goals. Do we want them to cut down? Do we want them to quit using? If psychoactive medications, do we want them to go and see their physician and talk about the psychoactive medications and see if there's some other things that they can use that will help them? Use a motivational enhancement approach. Slide. We want to end this by talking just briefly about, there's a lot of resources available to you on the website for the technical assistance program that this part of. You'll see the alcohol use disorders identification test, the short Michigan alcoholism screening test, geriatric version that Fred developed, intervention workbook. We will have a manual on there for how to embed things and how to work with it. IEEE has guidelines and guides, and SAMHSA, the Get Connected Toolkit, which has been a very effective and important toolkit that SAMHSA developed with COA, the National Council on Aging, that really helps people think about how to embed services for older adults into their system. So at this point, we're happy to take questions. Our contact information is on the last slide. please feel free to let us know what you need, or let Technical Assistance Center know what you need, and we'd be happy to help you. Because our other computer is not working, so we can't see the questions online, so someone is going to have to read us the questions.
Thank you very much. We really appreciate you all being on today, and we'll now open it up to questions. So I think, Kathy, you're going to coordinate that.
And Fred and Chris, I thought that was a really excellent presentation, very comprehensive on the topic of screening and brief interventions. And we had one question, Kate, if you can bring that up, towards the beginning of the presentation that I think you've partly addressed, but you may want to talk a little bit more about. And the question is, what information exists regarding drug use over the lifespan and the impact of that on current ADLs and pain management? Is there anything we should be aware of in terms of integrating a person's past substance use, even if they are no longer abusing today?
You know, I think that one of the things that I would say is that it's important to understand context for individuals, and if they've had a previous history of illegal use, so for example, if they used illegal prescription drugs that were obtained illegally previously, that to get high, you really want to make sure that you have a good understanding of that, because they may be at higher risk for developing serious problems in later life. So previous exposure, previous problems can relate to later life. What relates, you know, in terms of risk for diminishing IADLs, et cetera, that they've used it previously but are currently not using, we don't know anything about that. But we know that if we know that baby boomers had a lot of exposure to illegal use of substances, both prescription meds and illegal drugs, and that probably is a risk factor for potentially using them later on.
The thing I would say is with older adults, often when I'm talking with an older adult, and if one question I'm asking them is if they drink any alcohol, and they say, no, I don't, I often will ask, is there a reason that you don't? Because it's not unusual. Now, there are a lot of people who don't drink alcohol who are older because they're not feeling as well and they just don't have a good taste for it, or they never drank much, etc. But what you're looking for is somebody who says, well, I used to have a problem. Because some of what you can do is what Fred talked about on that slide on where screening and where brief interventions fit in the spectrum of interventions, is you can do prevention, and you can encourage prevention. And I think that's also a really important issue with that group. I think it'll probably be another half a generation before we have really good information on sort of long-term looking at people who use fairly seriously when they were younger, and what effect that's really going to have on their IADLs and ADLs later on. We hear things anecdotally, but I don't think we have a good research sense on that yet.
Thank you. While waiting for more questions, I just wanted to let everyone know that this webinar will be available. We are archiving it. We'll have the PowerPoint as well as the recording available, and we can send it out to the participants. It will also be posted on a number of websites, including the Administration on Aging, the National Council on the Aging, the Association of State Mental Health Program Directors, and the National Association of State Units on Aging. So available. Okay. The next question that we have is, what if clients who are drinking 2 to 3 drinks, or beer, might there be concerns about detoxing and the medical complications that can cause?
The tried and true guidelines, but based on consensus opinion of several of us in the field, we come upon the general consensus that one doesn't need to worry about detox unless people are drinking large amounts of alcohol and stop drinking cold turkey. So go high amounts to low amounts. The question is, well, what's a high amount? What we've come up with is just ballpark. If people are drinking, this is based on clinical sort of judgment and consensus with several people that I've worked with and talked with over the years, we're about 28 drinks per week, which is no 4 drinks or more per day. They really should be worried about detox. Now, the reality is most people detox on their own because they cut down on their own, and they end up having lower risk because of that. If someone tapers their consumption over time, there's really no risk for detox complications like seizures. So we will be vigilant that if someone is a high consumer, we don't advise them to stop cold turkey, but rather to cut down and taper their use. Or they need formal treatment depending on their levels of consumption. But in general, I would say that's only at the very high levels. I don't think you need to worry much about 2 or 3 drinks a day.
Thing is, as part of the brief intervention, there's a question that we ask the clients in the intervention that asks them if, when there are any days when they're not using, when woke up, did they feel shaky? We ask some questions like that, and what we're really looking for is withdrawal and potential for withdrawal. So that's important to, it's always good to ask some of that. There's some acceptable ways to ask that put people off and that help them to give really accurate answers. And we've got some of those that are available to people also.
Yeah, embedded in the workbook as Chris said.
Yeah.
Okay. Speaking of the workbook, we will send that out with the webinar link to the participants on the webinar. You both mentioned that several times, and it's a tool that really everyone needs to use to do brief intervention. So we will include that webinar.
Recognize that a webinar is really insufficient to be able to learn how to do these interventions, and we typically do trainings for people or more, depending on what the needs are for staff. So this will at least get you better oriented about what we're talking about and about the specific elements of an evidence-based practice of a brief intervention. But that it's going to be we expect you to be able to go into your clinic tomorrow and be able to conduct one. So we'll give you enough resource to be able to learn more about it, and then you might want more training.
One question we had is, can we repeat the suicide prevention webinar date? Okay. The next webinar that we will be conducting is going to be on March 21st, and the topic is suicide prevention, and it will take place at 2 p.m. Eastern Time. And those of you who are participating in this webinar, you'll get the notice for our next webinar, for the one on the 21st. Okay. Another question that just came in is the workbook available in other languages?
Some of it in Spanish, and that's it. We've used it in the past also in a project we did in California with Mandarin speakers and with Russian speakers, and had some translation of it, but we're less convinced that those are as well translated as they potentially should be. But Spanish, yeah.
Okay. Thank
you. In the book.
Okay. Well, we don't have any other questions, unless we want to